Good evening, everyone, and welcome to tonight's webinar, Optimising Cervical Screening for People with Disability, Supporting Equity in Your Practice. My name is Imogen Gregory. I'm the Education and Events Officer for the Specific Interest Faculty, and I'm really delighted to welcome you all online this evening. And I'd like to thank our partners for tonight's webinar, the Daffodil Centre, which is a joint venture between the University of Sydney and Cancer Council New South Wales, and also the Centre for Disability Studies. A couple of quick housekeeping items from me before we begin. So tonight, please use the Q&A box for any questions that you may have, as the chat function has been disabled. A recording of this webinar will be made available on the RACGP website in the coming days. And if you're an RACGP member, your 1.5 hours of education activity CPD will be uploaded for you within the next 14 days. And you do have the option to generate closed captions this evening. There's a little closed captions button at the bottom of your screen, so you can turn them on and off via that button. Once you've got them on, you can also click into the settings and change the color and the size of the text if you need to as well. And I'm really delighted to welcome our presenters for this evening. So we're joined by Tricia Maloney, who brings her life experience with polio and post-polio syndrome to her many faceted and constant works on behalf of women with disabilities. And Tricia is the former chair of the board of Women with Disabilities. We're also joined by Dr. Lara Roweski. Lara is a GP and practice owner. She's chair of the RACGP Board of Directors and of the RACGP Specific Interest Faculty. Lara is a member of the Australian Commission on Safety and Quality in Healthcare Cervical Screening Redrafting Working Group and Ministerial Advisory Committee on Bloodborne Viruses and Sexually Transmissible Infections. And also would love to welcome Professor Deborah Bateson, who is Professor of Practice at the Daffodil Centre and former Medical Director of Family Planning New South Wales. Deborah is leading an NHMRC study to increase cervical screening for people with intellectual disability, and she is Deputy Chair of the National Cervical Screening Program Clinical Advisory Group. And I'd now like to hand over to Lara for tonight's acknowledgement and to run us through the learning outcomes. So thank you so much, Lara.
Thank you very much, Imogen. I'd like to acknowledge the traditional owners and custodians of the lands on which each of us are joining tonight's meeting. I'd like to recognise their continuing connection to land, water and culture and pay our respects to elders past, present and future, and extend a warm welcome and acknowledgement to Aboriginal and Torres Strait Islander participants for tonight's webinar. We'll now take a look at the learning outcomes. So tonight we will be discussing Australia's national strategy for the elimination of cervical cancer, and we'll cover off the implications for people with a disability. We're going to identify the barriers and facilitators to cervical screening for people with disability, and we're going to promote strategies to facilitate cervical screening, including self-collection in people with disability. So I'd now like to hand over to Deb. You just go. Deb, we'll just need you to turn your mic on.
Good point. Thank you very much, Lara. And thank you, Imogen, as well. And it's a delight to be here with you all this evening. So thank you so much. I'd also just like to thank the Department of Health and Aged Care as well, who are also sponsoring this this evening too. So we've got a wonderful time ahead of us, and I'm going to get kicking off now by just setting the scene. And as you can see, it's a sober scene because one woman dies of cervical cancer every 2 minutes across the world. Each one is a tragedy, but we can prevent it. So this is Dr. Tedros Ghebreyesus. We all recognize him now after COVID, perhaps, where he's the Director General of the World Health Organization. And in May 2018, he had a call to action around the globe. So cervical cancer is a non-communicable disease we can overcome. So let's have a look at this global strategy. So we've actually got, since the shift, and it started really way back in the late 1970s, we suddenly understood that this cancer cervical cancer is caused almost universally, almost all cancers, cervical cancers are caused by the human papillomavirus. And that's meant we've been able to develop the tools and the technology to eliminate cervical cancer everywhere in the world within the next 100 years. And this is a global elimination strategy. These are ambitious targets for many countries, I have to say, to reach by 2030. And just to say, elimination is not eradication. It's fewer than 4 cases of cervical cancer per 100,000 women years. And these 2030 targets are 90% of girls fully vaccinated by the age of 15 with the HPV vaccine, 70% of women screened at least twice in their lifetime, at 35 and 45 with an HPV test, and 90% of women identified with cervical disease treated either for precancerous lesions or invasive care. And so the world has committed to eliminating cancer, and this is the global strategy here. So let's have a look at Australia, because we are actually on track to be one of the first countries to eliminate cervical cancer by as early as 2035. And just last year, the Assistant Minister for Health, Jed Carney, Honourable Jed Carney, launched the National Strategy for the Elimination of Cervical Cancer in Australia. And the key thing here is that we're really focusing on priority populations who we know can be underscreened. We must make sure no one's left behind. But just to cap on how we've got to this enviable position, so this is through our vaccination program. It started for girls in 2007, and boys were added into the HPV vaccine scheme in 2013. We shifted from a 4-valent vaccine to a 9-valent vaccine, so it covers 9 different types of HPV, and that was in 2018. And then a big change at the beginning of last year when we changed on the recommendations of the World Health Organization to a single dose, which is really great because it means that once someone's had one dose, they've actually completed the course. We also had the big shift, you'll all remember it, from pap smears to HPV tests at the end of 2017. That was a major policy change. And as you'll see, we also have had that major policy change to support self-collection, universal self-collection in 2022. We've also, the screening program is supported by the National Cancer Screening Register, and we'll hear more about that. But as I said, the key focus now is to ensure that we're not leaving anyone behind, that we have got equity when we're reaching elimination, and that includes people with disability. And I'm going to hand to you now, Tricia, to talk about upholding the health rights of people with disability.
Thank you. People with disabilities have the same rights as everybody else in all fields of life, and health is no different. And we do know that some people do miss out. And so for us, it's absolutely essential that we do make sure that women and, well, the girls with disabilities for a start get access to the HPV vaccination, that they get absolutely first-class access to screening, including self-collection, and then if they are diagnosed with a cancer, that they get the treatment that they need to get rid of the cancer if possible. The highest level of care is essential. But at the same time, we need to make sure that people have the right to autonomy. And it's often not understood that people do understand, in the most part, what is happening to them, and they can give informed consent under certain circumstances. And I'm sure that many of you know this even as well as I do. So thank you.
Thanks so much, Tricia. So important. And thank you for, just your voice there. It's marvelous to have you presenting tonight. And I'm going to hand to you again, really, Tricia, around the impact of disability on healthcare access and utilisation.
Yes, certainly. So approximately 4.4 million people have some form of disability, and it's probably higher than that if you include neurodiversity within that, which also has some implications for people's ability to access healthcare. So it's essential that we do include them. And with 450,000 people having an intellectual disability, it's really important that we understand how we can support them to be able to participate in the healthcare and to utilise the same things that everybody else is able to utilise.
Thanks, Tricia. And here we've got, a picture really around the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability. And we really know that that people with disability, there are really very high rates, aren't there, of sexual trauma and sexual abuse, which is very relevant, of course, when it comes to cervical screening for a variety of reasons. And
certainly there's a high level of sexual abuse of women with disabilities, and they're estimating that 95% of women with intellectual disabilities have had some form of sexual abuse over their lifetime. Jane, who's photographed here, is a friend of mine, and it's interesting to hear her story of institutionalisation, which also really impacts on women's ability to give informed consent easily or to participate without having their trauma relived. And that's what we've really got to keep at the back of our mind.
Thanks so much, Tricia. And, available data, and we don't have good data yet, but hopefully we're going to have it soon because of data linkage with the census and other large data sets with screening. But available data does suggest very low rates of screening for people with disability. We know as low as 30%, for instance, or even lower. One of the last studies in Australia showed a screening rate for people with intellectual disability as low as 10%. And what we know, of course, is that for people who are diagnosed with invasive cancer, almost 75% of those people are under or never screened. So we've really got to overcome these barriers to screening. Tricia's talked about those very high rates of sexual assault, sexual trauma, which can be a barrier, of course, to screening, particularly with a speculum. But of course, we also know that means that people are exposed to HPV and do need screening. So that's what tonight really is all about, is overcoming these barriers. So I'm going to hand now to you, Lara, and I know you'll talk together with Tricia around, just talk us through the barriers to cervical screening for people with disability.
Thanks very much, Deb. And look, I might start from the outset and say that GPs, together with the members of the practice team in which they work, have been shown to be very effective in increasing participation in screening programs in Australia. And we have convincing data to show that. We also know that people living with disability are the largest, and I don't like the use of this word, but the largest minority group globally. So putting those two facts and figures together, we know that all clinicians online tonight, GPs, practice nurses, will have people living with a disability coming into their practices. And I think it's very important that before we go any further, we'll go back to that slide.
That was my fault. Sorry about that.
Yep. Before we go any further, we put our patient at the very centre of the discussion tonight. We ask Trish to talk to us about what are the barriers that, Trish, people might experience when they come into general practice or a clinical setting in primary care.
Well, some of them find it extremely scary, especially if they come in without having somebody explain what's going to happen to them. So sometimes family members are reluctant to have the conversations, and then when they get in there, they find that they're having a speculum inserted, and they freak out, to be quite honest with you. They don't want to be touched. There are others too who just really overprotect the person with a disability. Don't allow them to speak for themselves. Don't allow the GP to explain what's happening, and we'll answer the questions instead of the person with the disability. We have some things around parents, for example. Some parents assume that people don't need to have screening because they assume that they're not sexually active. And we can never assume that somebody is sexually active, given the fact that there is so much sexual abuse within the intellectual disability community. Sometimes we don't have the information or a way of explaining how, and in simple terms, you know, we all tend to get technical, and we need to be able to explain things in a way that's not scary, but it's easily understood, and just take it slowly. Sometimes you might need to give a longer appointment because that's just helpful. And sometimes even the GPs lack that confidence in speaking to a person with a disability. As you've said, Lara, the GPs in this room probably all have people with disabilities in their practice, and so are probably well experienced, but others do not. And there's a societal thing around, there's a stigma attached to disability that sometimes that can be a bit scary for people with disability because they feel that they're not really well accepted by society.
Thanks, Trish. I think that's a really good point too, around the training and the education that GPs receive in this space, and certainly part of the RACGP submission into the Royal Commission also resulted in an identification that we do need to improve our training and education of not just GPs, but everyone that GPs works with in the clinic. One of the things that might be of interest to those online tonight is we certainly do have a disability-specific interest group, and that would be a great place for GPs who want to be surrounded by colleagues that are committed to providing high-quality health care provision, and collegiality around this might consider joining that group. Over to you, Deb.
Thanks so much, Lara, and to Tricia for this. And I was just looking here around the health systems and just that lack of accessible information, but also invitations. I mean, you will have seen the invitations, and there's been great work done in trying to, making them in plain English, but they can still be inaccessible for people with disability. So there is going to be work going on to improve this. So there's a real focus, which is fantastic, by the government in really ensuring that we do look across the board at how we can support people coming in for screening. So thank you both. Sorry, I jumped to this one a little bit prematurely before. So this is what we call a body map. This is part of the research project that I've got the privilege to lead, which includes the Chief Investigator with Intellectual Disability. It's called Screen Equal, and we're co-producing resources for people with intellectual disability, their families, and support people, as well as healthcare providers, to support trauma-informed care. But this is what do we call it? It's to overcome power imbalances between researchers and the participants. So instead of doing a qualitative interview, the people are invited to draw or write in an outline of their body about their experience. And this is about cervical screening. And this is just from last year. You can probably read some of this. It's quite disturbing sometimes as a practitioner. The process was painful. The doctor says, open your legs wider and wider. It was uncomfortable. It hurt too much. The doctor got mad at me for not following instructions. I told the doctor to stop. It hurt. I will not see her again for another go. And I cried after seeing the doctor. So it's just, these are really quite moving, and obviously, there is a way to go. I know obviously everyone here is going to be practicing trauma-informed care. Tricia, I just wanted to draw on you whether you thought this was surprising or not. Oh, Tricia, are you there? No worries. If not, I can move on. I'll just there we go. Tricia,
I'm sorry, I was muted, of course.
That's all right.
Look, I've sat in doctor's surgeries and seen somebody with a disability come in and they were fine and they had support workers. And as soon as they get into the doctor's rooms and they see the bed, they start yelling and it's traumatic because they just think, oh no, here we go again. And I mean, it's a reason why people don't come back for another screening, because it's been just too traumatic. People think that they're being over dramatic or they're just putting it on, but people are actually terrified because they've had something happen to them in the past, or it just generally hurts. I mean, it's not the most comfortable thing to have a speculum inserted, but
But now,
it may hurt.
Yes, we've got the new option of self-collection, so that's a really
goodness.
great thing. But let's come to that. But thank you, Tricia, for commenting there. So that's really important. And I'm going to hand to you here, actually, just around supporting screening for people with disability, around supporting decision-making, and, as you said before, about being in control of their own lives. So over to you with this one.
Absolutely. And I mean, we've found now, so we've changed as a society to how we used to consider people with intellectual disability. Now we understand that with the right supports, people can make a decision about their own lives. So we need to make sure that they are making the decisions and not somebody else. So it's not the parents saying, no, they don't need it, but rather the person with the disability is making the decision as to whether they have their screening. And it is the right of every person to have decision making in their own lives. And certainly the Office of the Public Advocate in Victoria has been doing some great work on ensuring the voices of people with disabilities are heard, that it's their story, not somebody else telling their story. All of the people in this room understand the legal status of consent to treatment and substituted decision making. I'm not going to tell you how to do your jobs, but just be aware not to make assumptions about people's ability to advocate on their own behalf, to make a decision about their own body.
Thanks so much, Tricia. Laura, do you want to add anything here?
Look, I think for most of us, we would document, and I think it is really important to document that verbal consent for CST or CST-SC, there's the acronyms we resort to when we're in a rush, has been obtained or given. There's no need to fill out the forms or anything like that. But I think we do need to at least tick off that that the person that we've been talking to about cervical screening or self-collection understands why they would be benefiting or what it is to gain from self-collection for them, and understands any potential side effects or adverse events. And I think we certainly do that in many ways across many other discussions we have in general practice. It is really important to ensure that we do, and I would suggest you do document that the option of self-collection was explained, and including follow-up, discuss any potential concerns the patient may have, and perhaps document, I often document patient agrees or something along those lines. So usually it should be straightforward. I probably would also suggest that if you do have a concern around substituted decision making, there's no reason to go ahead at this consultation. I would suggest that you might need to take some time to either make a couple of phone calls, certainly to your state jurisdiction, or your own, if you're particularly concerned, your medico-legal advisor as well, your MDO. Thanks.
Thanks so much, Laura. So I'm going to again hand this slide to both of you. It's around how to optimise care. We've talked about barriers, but what about optimising care? So over to you both.
Thank you. Tricia, you happy for me to kick off and then?
Absolutely. You go ahead.
So look, I'm just going to speak pretty plainly, actually, with the GPs here and the clinicians here tonight. And I think my overarching message is slow down, and which is exactly the opposite to what we do most of the time when we're in clinical practice. And I mean that in a number of formats. The first thing is we do need more time with our patients who are living with disability. So the first thing is find and offer the optimal appointment times, and that isn't at the end of the day. So late mornings, early afternoons, a time that's reasonable and understands that people can take a bit longer to get organised in the morning, organise transport and get to you. So the first off appointment isn't necessarily the optimal one either. When you're actually in the consulting room, you may be feeling a little bit anxious and uncomfortable yourself about this. So my advice is don't feel that you need to nail it at this consultation, and particularly with patients who perhaps have been traumatized or are fearful, or perhaps there are communication barriers or a third person in the room. Maybe it's about everyone getting to know each other and getting comfortable and having a conversation that's then followed up at a subsequent appointment. So remember, we do have the opportunity to book subsequent appointments and offer them. I also think part of really good communication here is not communicating in the way that you're used to communicating, but actually slowing right down and listening and giving time for responses. Using, and this is obvious, we always need to judge the appropriate health literacy level that we need to be speaking with our patients, and just being very sensitive to that. I won't talk about, you know, the concepts of simpler language, avoiding medical jargon, checking on understanding. I think also it's important to consider the use of models or a diagram, or even, I mean, I don't know if you can see it, but I don't go anywhere without that red top swab. So again, the sorts of tools that you might have available to you to support the information sharing. This appointment and often will be about managing a third person in the room. And I think Trish spoke really well around how that third person may not be an enabler, but a barrier. And I think it's really important for the GP or the clinician to take control and ensure that that third person is contributing appropriately. Remember, the third person is not a chaperone and does not fit the criteria of a chaperone, and don't get confused about that. So I think at this stage I'll see if you've got anything to add about optimising that environment. I'm sure you might, Trish.
Yeah, just a couple of little things, because you've just about done it all, which is great. Break the language into small pieces and don't assume that the person doesn't already have some level of understanding. Use correct terms for body parts. So they're not children. They may have a different way of understanding, but they do understand body parts. And I think your idea of a diagram is a great one. And the other thing I would add is talk to the person in the room, not to the person next to them. People make this mistake. Even if the other person answers, keep looking at the person you're talking to, because sometimes you can see by their body language whether they agree or not. And don't forget that people with disabilities have been taught to be subservient through institutionalisation. So sometimes they may be afraid to say yes if the person in the room with them has said no. If you've got time, try to see them alone for part of the consultation, but don't think you have to. Sometimes the greatest supporters are the support workers and the family members.
Thank you, Trish. And back to you, Deb.
Yes, no, thank you. Thank you both. That's a great overview of all that we can do to optimise care. So thank you. So I'm now going to turn to self-collection, and we'll just have a little look at this, just a refresher. So as you all remember, this came in July of 2022. And it really is a bit of a game changer in terms of bringing people into the program who may otherwise not be screened. So that's a great thing. So the key thing is HPV testing. There's still some misperceptions, we know, amongst the community, but also amongst healthcare providers about the equivalent accuracy, sensitivity of a self-collected test compared to a clinician. So a self-collected test from the vagina compared to a clinician-collected test from the cervix. And it was in 2018, in fact, where a pivotal study came out. It was an updated meta-analysis looking at all the studies and confirmed that, in fact, there is that equivalent accuracy when it's using a PCR test, and all the tests in Australia are PCR tests. So don't think that this is less accurate. So that's the first thing. Now, who can have a self-collected test? Well, anyone eligible for screening should be offered the choice between clinician collection and self-collection. It's still that choice, of course. So that's anyone aged between 25 and 74 with a cervix. Obviously, that's inclusive of trans people with a cervix and you know, gender fluid people. And it's anyone who's had any type of sexual contact. Now, HPV is extremely transmissible, so it doesn't just mean penetrative intercourse. So this also means oral sex, intimate genital contact, foreplay, for instance. But also, of course, as we talked about before, it can also mean non-consensual sexual activity as well. So who can't have a self-collection? Well, that's actually anyone who needs a co-test. But we've also got other places in the pathway where self-collection is a very useful way forward, and that's for people, as we'll see soon, on the intermediate risk pathway, people who have not 16, 18 HPV result with a negative or a low grade cytology results. So we'll have a look at them. But anyone who needs a co-test can't have self-collection, because it's not, a co-test is where the lab automatically tests for HPV, and on the same sample, they test for cytology. Now, with a self-collected sample, it can only test for HPV, not for cytology. So if someone's got symptoms, for instance, that needs a co-test, it can't be self-collected. So that's just an important component. And this is exactly what I've just said here. So self-collection detects oncogenic HPV DNA, and we've got partial genotyping. So that means we can tell whether we've got a type 16, 18 or 18 HPV type. These are the most oncogenic types, the types of HPV which are less likely to clear from the body, more likely to progress, and more likely to go on to develop into cancer about 10, 15 years down the track. Now, most, of course, will clear, but you know, it determines our pathways. And then it also detects the non-16, 18. They're much more likely to clear, less likely to go on to develop it into cancer. Whereas type 16 is a unique carcinogen. In fact, it's really, you know, type 16 is the type of HPV that's associated with most cancers around the world, and 18 comes after that. As I've said, the self-collected sample can't be used to detect cell changes. So let's have a look. We follow a traffic light process, of course, and we divide our test results into low risk, high risk, and intermediate risk. So let's have a look at the self-collection pathways. So the majority of patients that come along, people that come along for routine screening, are going to have no oncogenic HPV detected. It's over 90%, and we know there's a very high negative predictive value. It's safe for them to go away and return in 5 years, unless, of course, they have any symptoms, in which case, suggestive of cervical cancer, they need to come back to see you. But low risk, come back in 5 years. With a self-collected test, they don't need to come back to see you for a cytology test. What about the higher risk group? So this is where HPV 16 and or 18 is detected. Well, these people are at higher risk of cervical cancer or having a pre-cancer. So what happens with this group is, again, if it's self-collected, they don't need to come back to you for cytology. If it's clinician collected, the lab will perform reflex liquid-based cytology. But the key thing is that for anyone who presents and has a higher risk result, and it's around about 2% of the people who turn up for routine screening, they're referred for colposcopy. So that's important. And then there's the group in the middle, and this is where the pathways do a little bit different for clinician versus self-collection. So this is where on the self-collected sample, HPV not 16, 18 is detected. This occurs for about 60% of 6% of patients overall who present for routine screening. It's actually higher in younger people and lower in older people. That's because younger people are more likely to contract HPV, as you know. But the key thing is that you actually haven't got a risk rating until that that cytology has been performed. If it was a clinician-collected sample, then the lab would automatically, if any oncogenic HPV is detected, the lab automatically carries out that cytology on the same sample. But that can't happen on a self-collected sample. So in fact, that patient, it's really important when you're explaining about self-collection that this is a possibility, that if someone has this NOT1618, they do need to come back to you or someone in your practice to have the liquid-based cytology performed. And that does mean a speculum examination, because the risk isn't determined until that's happened. Because this person could come back, they've got NOT1618, but they could, for instance, have a high-grade or a possible high-grade cytology result, in which case they'd have to go for colposcopy. But if they've got a negative or a low-grade or a possible low-grade cytology result, then we know it's safe to watch them for another year. And this is, you've probably all seen this, it's quite bamboozling. Just to say, we're updating the guidelines now. We're going to make, they're going to be coming out later this year with all the new evidence. There are some changes, but the key thing is we've brought all these flowcharts together. We've got a special chapter for primary care aimed at GPs and nurses, so making them much easier to navigate. Just to go over this very quickly, we've got the traffic lights again. So on the left-hand side, this combines clinician and self-collection. If HPV is not detected, come back in 5 years, routine 5-yearly screening. If on the right side, there's 16 or 18, the highly oncogenic types detected, there's either reflex liquid-based cytology on the same sample, but those people are referred for colposcopy, and if it's self-collected, then at the colposcopy appointment, that cytology will be performed. It's the group in the middle there, not 1618. If it's self-collected, they have to come back to see you for the cytology test to inform the risk. If it's intermediate risk, then they're safe to watch for another 12 months. And then you can repeat the HPV test. That could be self-collected again in that 12 months. And again, if it's HPV 16, not 1618 detected, for most people, we know it's safe and they've got negative or low-grade cytology, it's safe for them to be watched for another year. If it's persistent 24 months after their first screening test, then they're referred for colposcopy. There's a few groups, if women are over 50 or more, Aboriginal and Torres Strait Islander women, or those who are overdue for their initial screening, if they have persistent not 1618, regardless of cytology, at that 12-month follow-up, they're referred for colposcopy. And I just wanted to show this. This is really heartening. This is what's happened. You can see where you see the line going right up. That was when universal self-collection was introduced, and you can see now, in fact, we're further on than this now, but so over 30% of all screening tests are self-collected, and it's reaching the people we need to reach. It's under-screened people in remote areas, Aboriginal and Torres Strait Islander women, and actually, interestingly, women over 70. We're still not attracting as many of the 25-year-olds as we need to, by the way. So that's just something to think about. Tricia, what do you think about these self-collected figures? Does that surprise you?
No, not at all. And I know in my community, we've been hanging out for the self-collection because it makes our life so much easier. Unfortunately, I'm one of those ones who are HPV positive, not 1618. So I keep having to come back for the speculum, which is really annoying because I was really looking forward to not having to do that. But that's the way it is. And my whole family all come back each time as HPV, not 1618. So I don't know what the glitch is there. But definitely many people are really, really happy and are happy to do self-collection.
Fantastic. It really is a game changer, as you say. So thank you. Thank you for that. Now we're going to just introduce you now to Lisa. She's 34 with an intellectual disability, and she attends with a support worker for a checkup. And we look up her screening history through the NCSR provider portal. And I'll hand to Lara in a minute about the register. But what we find out is that Lisa's only had one prior cervical screening test. It was negative. It was 10 years ago. She's not sure whether she's received invitations to rescreen or not. And in fact, in this situation, the support worker does talk for Lisa and talks over Lisa. And it's clear that Lisa actually does want to be seen alone. You ask her if she wants to be seen alone, and she does disclose prior sexual assault and tells you her last screening experience was actually traumatic. So you feel confident to manage this situation because of a recent update on trauma-informed practice. But before we go to that, I just thought I'd turn to you, Lara, if there's anything around the register and how useful the register is. I know that obviously you can connect through your medical software now.
Yeah, thanks, Deb. And look, I think there's been a great sort of improvement in the last year or two in terms of accessibility for GPs and practice nurses around the National Cancer Screening Register, which of course houses data both for the National Cervical and Bowel Screening programs. I think now we are able to do what we need to do, which is access real-time information during a consultation or just prior. If we know that's what the consultation is going to be about, it really is quite quick. We do that through having set up access. And if you haven't got access set up, your practice manager or practice nurse should be able to talk you through the steps. And then it's really just a click of a couple of buttons. And what you have before you is the sort of information that you need at hand to actually guide your own clinical decision making in terms of either the sort of tests that a patient may be due for, and you'll be able to work out if or confirm in fact a previous screening history or anything relevant that might actually mean that today's this patient's not in fact eligible for self-collection and they're eligible for another type of test or follow-up process. So I'd encourage everyone to find their own screening results on there for a start, have a bit of a practice and just really start to incorporate it into your everyday clinical practice. Get comfortable with it, use it. I think it is important to be across the screening history of any patient that you're offering and supporting self-collection or the clinician collected pathway to, because it informs actually clinician decision making around what's the best next step. Thanks, Deb.
No, thanks so much. So let's come, thank you, Lara. I'll do this one. Let's come to trauma-informed practice, which seeks to address the barriers that people affected by trauma can experience when accessing healthcare and care services. And we know we can't make any assumptions. We have to think that maybe any patient that's sitting before us has been affected by trauma, and the aim of trauma-informed practice is to minimise the risk of re-trauma. And Tricia, I know you were going to talk to us a little bit about this. Thank you. Now we can't hear you there for some reason. Let's see.
Now, sorry,
Thank
here
you.
I am. We know that there are many women with disabilities, and particularly intellectual disabilities, who have been traumatised by sexual assault at whatever level that means. And we know that sexual assault or the trauma from sexual assault varies from woman to woman. But when you have never had the chance to say anything, you've never had the chance to disclose, or if you have, nobody's ever believed you, then it can be quite difficult to then come into a doctor's surgery and have somebody want to touch you. And keep in mind that the people who have sexually abused these people are generally people that they're supposed to be trusting. So it's honestly, sometimes it's support workers, sometimes it's other family members. So I think we just need to keep that in mind whenever we have any disclosures. And I'm sure that any of you who have done any family violence training will understand this. And the training that you've received through the family violence training will hold you in good stead for this.
No, thanks so much, Tricia. And you're right. It's what we all practice all the time, just checking in with the patient, explaining each step, and importantly, saying that this you can stop at any time. So I think that's really, really important. As you said before, Lara, if you don't feel, it may take a few consultations to reach a place where someone is wanting to go ahead with self-collection. But over to you, Lara, just around trauma-informed care.
Look, I think particularly in general practice, we've realised that this is really an emerging and an important area for us to skill up in. And I would argue that we're not going to be able to do it justice here in tonight's webinar, but what we will do at the end is Imogen will talk to us about some of the resources the RACGP has in place for GPs. But I do want to highlight again that we have two specific interest groups, the abuse and violence in family specific interest group, which there are thousands of GPs who have joined that group, and also the psychological medicine group. And our SIGs have collaborated and produced some very helpful 1 hour on-demand webinars that particularly are on cover of trauma-informed practice. And I would commend to you, if you've got an interest in it, certainly you'll get your CPD points, and you can find those on-demand webinars if you go into the CPD portal using your app. Thank you.
Thank you, Lara. So we do take Lisa's history, and she does, we explicitly asked about whether she's got any symptoms that could be suggestive of cervical cancer. And I will stress that this is particularly important. Just when you're offering self-collection, it's not just a matter of saying, here's a self-collected swab. I've got one too in my handbag. So it does have to be accompanied by a history, because it is true that it's really important, because if someone has got persistent postcoital bleeding or unexplained intermenstrual bleeding, postmenopausal bleeding, we've got to be able to elicit that, because the patient doesn't know that they can't have a screening test. Of course, they'll of course say, yes, I'll have a self-collected test if offered, if that's what they want to do. But you must elicit that history, because it could mean often these people maybe with disability may be very under-screened. They may not have had screening for many years, and that does increase their risk of being one of those numbers of people who do develop cervical cancer. So do take that history. But I'm going to go now to say Lisa decides she wants a cervical screening test. She hasn't got any symptoms suggestive of cervical cancer. So Lara, talk us through this consultation and what you would do.
Thank you, Deb, and I'll invite you to join me too, just to make sure we cover everything off. But look, the first point I want to make is there's actually been a paradigm shift, I think, in the way a GP should be approaching this type of consultation. And I'm going to speak about it in general terms and obviously try to be considered and inclusive of our patients who may be living with disability. So what we should be doing at the outset is offering choice. So there's no longer room for us to be making an assumption that we're going to be inserting a speculum and going down that pathway. And this is in line with the National Cervical Screening Program guide now, which is compelling evidence to show that self-collection is as accurate as clinician collected, and also it's highly acceptable. So it's exciting because we can develop now a real partnership with our patients and actually offer them the choice and take them through these options and really then support a preference, bearing in mind, of course, the history and also the cervical screening history should have bearing on what is an appropriate choice. So it's important that we explore that with our patients. I'm going to talk specifically about supporting self-collection, and I think what we need to do again is ensure that we have everything at hand to support a consultation. What do I mean by that? I think it's really important that we do show people the swab, and not only that, we take time to explain how they would actually perform the test themselves. So Deb and I have shown you the swab, and I will make it a routine part of my consultation to actually show people the swab. I'll actually open up the swab and actually show them how to unscrew the swab. Don't assume that everyone's got the strength to open up that swab actually. So once you've opened the swab, and I've got mine open here, I do point out to patients that there's a soft tip, which should feel soft and comfortable when it's used properly. I think it's really important to take away fear and provide some reassurance around comfort. I think it's really important to explain how one would hold the swab and where in fact this test would occur. And so we need to think about a place that supports privacy and dignity. One of those places could be, the bathroom, or it might be behind the curtain in your room. You can support this through telehealth as well. So it might be in the patient's own home, or it could be as part of visiting a residential setting. So you need to think about where this is going to happen. You should give very clear, specific instructions around preparing to take the test. So people need to understand that they'll have a private place. They'll need to remove their underwear, for example, it's so important that people understand their anatomy as well. So don't assume, and unfortunately when we talk about trauma and pain, we had a patient last week who, despite our best efforts, swabbed their urethra and returned in pain, quite distressed. So even though self-collection is there to offer, I think, the opportunity for a more dignified, respectful process, it too can cause trauma. So perhaps understanding the level of a person's comfort with their own anatomy, understanding where the vagina is, being able to locate it. I would often give very specific instructions about how far the swab needs to be inserted, explaining to them that it's a sample that's taken from the vagina. They don't need to actually sample from the cervix. Some women think they do, in fact. Needs to be rotated at least 2 to 3 times so that an adequate sample is taken. I'd actually talk to them about how to return the swab, how to place it back into the holder. And then timely return of the swab is important. So certainly we don't want swabs to go missing or lost. And I think that's one of the important reasons why there's a strong preference for this to occur in the clinical setting. And explaining, I guess, that the swab comes back to you or it's dropped off at the front desk. I sign off all swabs, even when they're dropped off at the front desk. I'll ensure that I've cited it in the collection box and I've signed it off, and it's my responsibility to ensure that that swab gets to the lab on time and is interpreted. You should also check throughout all of this that the patient is following those instructions and is happy and understands. I think, Deb, I might go to you.
Look, I think you've explained everything. I think the one thing that is important as well is to ensure that that person does have an understanding of what will happen with the result, when the results come back. So if it's negative, another 5 years, if it's 16, 18, it can be quite complex to explain, of course, and we're actually working with putting things into easy read at the moment for people with intellectual disability, to colposcopy, and that there is that chance. So for both of those, the majority of people won't have to come back to you for a cytology test, but there is that 6%, and it may be higher for people that haven't had screening for a long time or whatever. Will need to come back for that cytology test. So, and I think it leads me really nicely to the next slide. Well, Lisa chooses self-collection, but she's worried about taking a sample herself. And that can be for a variety of reasons. There can be people who can't take it themselves. They may have a tremor, for instance, or just a physical disability that precludes them. But they could also just be lacking confidence and around their anatomy and feel really worried about it. So that person must know that they can actually ask you to assist them with taking that sample. So Lara, do you want to talk us through that?
Yes, absolutely. Thanks, Deb. And look, a range of patients may express this. As Deb's described, there's some of the reasons, and we also have low vision patients. We have patients with Parkinsonian tremors. We have patients with quite significant arthritis or hip arthritis. And I think we have a range of patients who actually just don't feel comfortable performing that sort of sampling, and their preference is that you take it. So there's no problem with the GP or the practice nurse assisting with this. Essentially, you should make sure that you just label the swab as self-collected. There's no need to write clinician assistant or, I helped or anything like that. It will still be treated as a self-collection by the laboratory. Thanks, Deb.
No, thanks so much. So with Lisa's consent, you do take the vaginal sample for HPV testing. And we're going to just come to a little bit around the lab now, and over to you, Lara.
So thank you. So it's quite important that clinics that want to be offering this option proactively, regularly, and in fact routinely for all cervical screening need to have a really good relationship with their lab. Often GPs are busy, and it might be the practice nurse or the practice manager that needs to ensure that the whole clinic is well equipped with the correct sampling devices. There are currently two options in terms of taking an accurate, valid sample. One is the red top dry swab, which we can see on the slide. It's the first picture there. It's the one Deb and I hold dearly in our purses and on our desks. We like it because it's one step. That sample needs to be back in the lab within 28 days of the time that it's taken, and it's a one sample device, and it's safe to use as well in pregnant women. The other option, and different labs support different testing platforms. So your local lab will either do one or the other. The other is the sample is taken with the swab, but then needs to be swirled for about 20 seconds through a thin prep vial. The time between when the sample is taken to when it needs to be inserted into the vial and swirled through and then discarded is probably no longer than a few hours. It's not an overnight job where you can swirl it through the next day. That is the preference of the lab, and to maintain that accuracy. So your local lab will have a preferred testing platform, and they will supply you. And please ensure that these sampling devices are in your room, not a long way down the corridor and then a disincentive for you to support self-collection because you just don't have time to get down the corridor and find samples. Please ensure you know which platform you're using, and then your lab will have will either be processing these tests themselves. So, for example, here in Victoria, VCS will process the red flock swab. Some labs will send on for processing, and I think it's important that you know what your local lab can and can't do, and that's as simple as a conversation. Please label the sample. I often use CST/SC, which is cervical screening test self-collection. And generally I'll tick the box self-collection on the request form as well. Thanks, Deb.
Yes, thank you. And I'll add in, if you like, just it's really important to ask. Don't make assumptions about whether people have Aboriginal or Torres Strait Islander status or background. Do ask and do record it. And the reason for that is not just because it's really important that we've got that identification, so we can understand what's happening with this population. So, and we know that Aboriginal and Torres Strait Islander people really want us to ask. And it's also because it does impact on the clinical management. If you remember back to the intermediate risk pathway, if someone has persistent non-16-18 at 12 months, rather than waiting another year, they're actually, this group plus women or people age 50 and above, and those who are overdue for screening, they actually are referred to colposcopy straight away, rather than waiting for another 12 months. So that's just important to understand. So let's come back to Lisa. So Lisa's test comes back as HPV 16 detected. And what do we do? So if you remember, that is one of the highly oncogenic types. So let's have a think about what we do in that situation. So of course, Lisa does actually need referral for colposcopy directly. She doesn't need to come back to you for the cytology. You will refer her to colposcopy. Let's have a look about supporting underscreened patients, because what we do know is that patients with HPV detected may require additional and individualized support to progress along the clinical pathway, to access follow-up services. It may be through an Aboriginal health worker, for instance, and you know, just needing those extra appointments is really important. But you also need to give that extra reassurance and explanation of the pathway and follow-up procedures. So just to come back to Lisa, but I suppose it is, you know, I know I'm working with people with disability. I really want to get in touch with the colposcopy service just to let them know, so they're aware and they may need additional adjustments made for their service. Lara, did you want to add anything to this around supporting under-screened patients?
Look, I think what's important is, I guess, that for some of our patients that are under-screened, we need to perhaps explore some of the I guess barriers and some of the experiences that they bring. So for some, it might be an experience of pain and discomfort, and certainly this is where self-collection is really important. For some, it might be cultural barriers or embarrassment or fear. And again, self-collection really overcomes many of those barriers. For others, it's actually a health literacy issue. They've come from a place in the world where sometimes, actually, interestingly, I've had patients that are highly suspicious of systemised government initiatives and really don't want to actually necessarily engage with a program like this. And you need to spend some time educating them about you know, the fantastic screening program Australia does offer Australians. Religious barriers, sexual trauma we've talked about, and abuse, really, really important. Unfortunately, just a previous negative experience with having cervical screening before. Preference for a female, really important as well, and preference for a chaperone or someone in the room. So again, there are so many ways in which we can adapt what we do to increase, I guess, confidence and comfort. But again, I think for each of those scenarios that I've discussed, self-collection just comes up trumps as overcoming, I guess, many of those challenges. And that's why, I mean, in my practice, I find it really, and it's the heart sink when you really know that someone would benefit from screening, because let's face it, the game we're in is preventing cancer. So to be able to offer the opportunities, really great.
No, thanks, Lara. And I think, as you say, it's so important to be able to offer that self-collection, but it is also recognising that for people who do have a not 16/18 result, for instance, they'll need to come back for a speculum examination. And in Lisa's case, she's HPV-16 is detected. So she will need that referral to a colposcopy. And what we do know from the available data is that we often lose people at that point. So that step to a colposcopy, it may be for factors of travel and cost, but also it can be just, you know, that great unknown about what colposcopy is, and people may have heard some negative experiences from others. And of course, if someone has a 16 or 18, you know, detected, they're referred for colposcopy, but they don't go, you may as well not do the screening at all, of course. So because that's the important component then to be able to the next step for that colposcopy, possibly a biopsy, and then treatment, if appropriate, for a precancerous lesion. So Lisa does return with her support worker. We explain the result, and we do actually give accessible information to take home. So do look at all the excellent resources on the NCSP website, and there's going to be more developed for people with disability as well. And we do organise another appointment to discuss a referral to a colposcopy service. Now, saying we're referring you to a colposcopy service will mean nothing to most people, of course. And so you really do have to have those props available to you. There's some excellent wording on various Cancer Council websites, and how I would explain, and Tricia, I'll be interested to know how you both do it, but is you know, a colposcopy is like a large magnifying glass. It is, again, taking a close look at the cervix. So again, we're explaining, you know, what a speculum is, but taking a close look at the cervix. It is placing some liquid on the cervix, which can show up any abnormal areas, but it is having that close look at the cervix, and then some small samples may be taken to see what's happening and whether that person does need treatment or not. Tricia, is there any other, how would you explain that?
Well, I would have explained it just as you've done it. I would say that if you're taking a small sample, you might need to explain what that is.
Yes.
So it, just, and you do this all the time, so it should be easy for you to do it. That it's not as though you're going in there with a pick hat and taking a large piece. It's just a very, very small little scrape, so that you've got some tissue to be tested.
That's right.
And even the word abnormal, to see if there's anything not right with it.
Yes.
And to fix it if it isn't right.
Yes. Yes.
So I think to fix it is the way to do it.
Thank you. Excellent. I'm going to use that from now on. So to fix if it isn't right, and you're right, it's about checking that things are healthy, but if they're not, it's then fixing it. Lara, have you got anything to add in?
Look, I think the real important message here is the way that we do that initial work with the patient when we're talking to them about self-collection, and that we actually work through the ramifications of a positive result. Yeah. And I think that's what we call pre-test counselling. We do it for other testing where there is significance when a positive result comes back. And I think it's just taking the time to sort of set that up. You don't want to labour it to the point that you put people off actually engaging with the test, so you need to be really careful. But I think you sort of do need to reference either the follow-up speculum exam and the percentage. It's not a lot of people, as we know, right, Deb? So and then an even smaller number of people who might need a colposcopy. I think GPs do develop and have relationships with local colposcopy services. Now's the time to cash in that relationship. So do we need a support service there? Do we need a community worker there? How does the service actually work to support people with disabilities? What can you do to advocate on behalf of your patient? So they're all the things that are within the remit of a GP to actually smooth the way. And I love the fix it.
Yes.
The simple fix it. Thank you, Trish.
I'm going to use that now. That's great. Well, look, we've come to our last slide. I'm conscious of time before we just wrap up. And obviously we want time for all your questions. So really, I think we've probably covered this. What if Lisa needs a clinician collected sample from the cervix? I mean, that might be because she has not 16/18 and needs to come back for that cytology test with you. And of course, if she needs a co-test, you've taken a history. It might be for a variety of it, but maybe she's got symptoms suggestive of cervical cancer. She needs that clinician collected sample. So that's explaining, again, having your props, explaining what's going to happen. Tricia, I think you also gave an excellent explanation of that last time. I remember. How would you describe the speculum examination?
It's just a way of opening it up so that they can have a look inside easily.
Yes.
And so it's not too painful. It's just really uncomfortable, but it's fine.
Yes, that's right. And again, I think it's important to remember there can be distraction techniques for people as well. So again, it's about taking it slowly. As Lara said, you're not rushing, you're explaining at every step, and you are saying, I can stop any time if you want me to. So that's important. So look, we've had a fantastic session. I'm just going to do some take-home messages and hand back to Imogen, but do think about all your questions and put them in the right place so we can answer them all. So Australia is on track to eliminate cervical cancer by 2035, but we mustn't leave anyone behind, including people with disability. We know cervical screening rates appear to be very low, and that's because of the multiple barriers we've heard explained so well. And GPs, of course, you play an essential role in supporting cervical screening for people with disability, using that trauma-informed care approach, and you've got lots of resources which we'll share with you after this. And self-collection of a vaginal sample can be a useful choice for this group. And just remember that if a person requests it, then you as the clinician or your practice nurse can take a vaginal sample. It's still classified, even if you've assisted, as self-collection because it's a vaginal sample, and that's important, needs to be labelled. People with disability may need additional supports to progress along the pathway and to be referred for colposcopy, as we've heard. And there's lots of excellent resources to support your practice. So I'm going to end there. I'm going to hand back to Imogen. So Imogen, you're going to talk us through the next few slides. Thank you.
Yeah, Thank you, Deborah. So you've just mentioned resources, and there are many. We've highlighted a few of them here, and all of these hyperlinks will be emailed across to you as well. So we do have the National Cervical Screening Program Clinical Practice Guidelines and the Provider Toolkit. There's, of course, the National Cancer Screening Register Quick Start Guide as well. Next slide, please, Deb. There's also a really wonderful mini audit that's been developed by the RACGP on self-collection for cervical screening, and that's available to RACGP members via GP Learning. It's not onerous. It's a really wonderful way to get those 7 CPD hours, of course, and improve those outcomes for your patients. And so far, we've had over 2,000 GPs enrolled into that, which is really fantastic. So you can access that via GP Learning. And next slide, please, Deborah. Thank you. And earlier on, a discussion around trauma-informed practice, and these are just some of the resources that we've picked out for you. Of course, on-demand webinars that Lara has mentioned. There's the White Book, Chapter 7, and the GPMHSC has got a really wonderful trauma-informed care resource hub, as well as literature review on trauma-informed care and practice. I know we've talked about the psychological medicine and abuse and violence and family specific interest groups, and you can become a member of either of those groups really easily online via a quick online form, which I can direct everyone to in an email tomorrow as well. So I'll hand over to you, Deborah. Thank you.
No, thank you. We'd just like to invite your questions and acknowledge Dejan Kristek he's the director of the National Cervical Screening Program, and colleagues at the Centre for Disability Studies and Daffodil Centre. And I'm going to stop sharing my slides now, and we can open up for questions. So I haven't been able to see the questions, I have to say, so because I've had the slides on my computer, but I'm sure, Lara, you probably have.
Yeah, look, we sort of have a 3 questions on a similar theme, which is really around what happens in terms of Medicare rebate or charge if people are presenting a little bit early or a little bit late for the 5-year. And I think one of the participants, Tina, who I know well, has pretty well given a fairly accurate response. But from my perspective, this is where your relationship with the lab is really important. People living with disability will have a whole lot of reasons why they may be early or late. I pick up the phone and I ring up the lab and I say, how can we make this work? The labs have to work pretty strictly too, and they know the rules around sort of how early and how late, and there is leeway there. But I often find this is the time where that relationship can work really, really well around minimising any unexpected charge to your patient. And I would suggest that if you're unsure, that you do want to mitigate a patient receiving an account, and I would make a call to the lab, particularly when you know they're early. And it's probably more than just a couple of months early or a couple of months late. Either way, there's leeway.
Yeah, I mean, the rules, the Medicare rules, as someone has correctly said, so it's 3 months prior. I know there was a little bit of a challenge at one point because some of the letters seemed to go out a little bit early.
That's right.
And people, if they turned up on the very day they got their letter to say, come and you're due for your screening test, they would have been charged for it. So, but you're absolutely right. You know, there may be reasons why, you know, obviously having that relationship with your lab to waive fees in appropriate circumstances is very clear. But again, just to say, this is where the access to the screening register is so important, because you can see actually, you know, there and then in real time whether someone is due or not.
Yeah. And there isn't an advantage to extra tests in between the 5-year interval when you've returned a negative result. So we would strongly discourage that.
Yeah.
It's really over servicing and it's not conferring benefit. Yeah.
That's right. So are there any other questions? Please give us some questions. That would be great.
While people are thinking about questions, I do want to endorse that mini audit. It's hard for GPs to get the reviewing points in the CPD. And one of the advantages of self-collection that we perhaps haven't talked about is the fact that it brings our male GPs back into the fold. So for many men, perhaps they weren't as keen to be involved in clinician collected sampling. So self-collection makes it an even playing field now for all of us again. So welcome back, male GPs. And the other thing is, of course, our environmental medicine SIG, of course, rightly pointed out, the less plastic speculums we use, the better for the environment. And you'll find that the mini audit does give you an opportunity to count up how many plastic specula you've actually saved using through promoting self-collection. So I thought they would just be some interesting points I could make tonight, Deb, in or supporting self-collection in practice. Now, I'm not sure we've got any further questions from the group.
Oh, there's one coming up.
Yeah.
Yeah.
Yeah, we usually get that question. It's a good one. What would you like to do, Deb? It's the question
I'm
around.
just looking at it now.
Yeah. So if someone's not been sexually active, do they need a self-collection or indeed cervical screening?
We have a very low, I mean, if someone has never had any sexual contact or any chance of that sexual transmission, it is a very highly transmissible infection, as you know, then no, they don't need cervical screening. But I think you need to have a very open mind, I suppose, and obviously you're not going to pressure anyone into having a cervical screening test. So people need to actually have the option to have a cervical screening test or not. But there may be many situations, and Tricia, I know you'll add into this, where people may be reluctant to disclose that they're sexually active or they've had sexual trauma in the past. So I think it's really important not to make assumptions. And I think if someone comes in to request cervical screening, obviously you're going to give it to them or offer it to them. But if they are age eligible, and you look up and they haven't had cervical screening, I think it's appropriate to offer it. And we do know from the surveys in Australia about proportions of people who are sexually active by the age of 25. It used to be 18, as you know, but that's changed now. Then that is a high proportion. But I think it's about making no assumptions. But if someone says, I've never, ever had any sexual contact, then absolutely they don't need to have a screening test. Tricia, would you like to add anything into that?
Yeah, I would err on the side of caution.
Yeah.
Because there's a couple of reasons why women with disabilities don't disclose.
Yeah, exactly.
Because they've been threatened with violence if they do. So that's one thing. They're ashamed because they think it's their fault, so they don't disclose.
Yeah.
And sometimes they don't even know that they've been sexually abused. Sometimes the only way we find out that women with disabilities have been sexually abused is when they are pregnant. And they have no knowledge of what happened to them. Sometimes they just don't have the capacity to speak on behalf of themselves. And I will tell you too that as a woman with a disability, women with intellectual disabilities disclose things to me that they don't disclose to anybody else. Because in the same way that women disclose to each other, women with disabilities disclose to other women with disabilities, because it's a place of trust. So I really think we just don't know whether people have been sexually active.
I think it's a really important point, Tricia, and I must say I've had quite a few conversations with people where they have said that the doctor or the nurse didn't offer it because there was an assumption that people weren't sexually active. And so I think you have to offer it. This is a test that can save people's lives. And I think if people are agreeable to having that test, you don't know, as you say, you just don't know, Tricia, and people may not want to disclose that they've been sexually assaulted in the past, for instance. And you heard, those very high numbers, particularly for people with intellectual disability around sexual trauma. So I think it's having that very, just offering it. And again, it's within that trauma-informed context, recognizing that any patient sitting before you might have experienced sexual assault or child sexual assault.
And I think we've all got the right to say no.
Absolutely. Yeah, absolutely. Sorry, Lara.
Yeah, no, I was just going to actually talk about how you'd handle this actually in the clinical setting in general practice. And I think it's not dissimilar to chlamydia screening or others. So the first principle that's important to understand is any type of sexual activity puts you at risk of HPV transmission. And often people have various their own perceived views of what sexual activity means to them, and that's speaking a little bit to what Trish was speaking to and Deb. I think what's important is that we're very clear about the age eligibility. We're not looking to offer or support proactively below the age of 25. There are some caveats to that, and particularly women who are pregnant earlier than 25 may be a caveat. But from 25 onwards, it's really about providing people with the information around if you've ever been sexually active, and perhaps talking a little bit around that, but not seeking a specific, oh, yes, I have, just allowing them to then make that decision. We do it beautifully with chlamydia. We basically say, look, at this practice, we support an annual chlamydia test for anyone aged up to 30 who's ever been sexually active. Would you like one? So we can sort of take that approach as well, and different patients will be wanting to talk to us about that in different ways. Thanks, Deb. Thanks.
No, that's great, and I think that approach is really the way to go. As you say, this is for everyone. Cervical screening, we offer it to everyone from the age of 25. Would you like this? So I think that's a really great way of framing it.
Now, we have some more questions, which is great. I'll take the one that's come to me a bit about how far to insert the self-collect swab. Look, actually, Caitlin, I give them precise information about this. I much prefer that they are given something precise. So I encourage patients to hold the swab and hold it at where the red marker is. And I tell them that if you're holding the swab where the red marker is, and you may want to try this yourself, the swab's very stable. If you're holding it right at the end, it wobbles around a lot, but that's at the 8 centimetre mark, and we do not want the swab to be inserted beyond that. So I said, look, where your fingers are, you shouldn't be reaching that. I show them the tip, and I basically say that needs to go inside the vagina, so you don't want to see it. It doesn't really matter if you push up a little bit higher or just pop it in, as long as you then spend at least 10 seconds in there rotating it 2 to 3 times. And I use my fist, and, this is the vagina, and literally, actually, I'll be showing them, hold it where the red marker is. We don't want to insert that far, insert inside. As long as you can't see the tip, you're right, and turn it 2 to 3 times. So I hope that helps. Deb, we've got some other questions too.
We do. We've got the one about doing self-collection at home, and how long, can you wait before that? If you've got the Roche system, that's the system which requires the suspension in the liquid, the thin prep, the liquid-based medium. I would say, and Lara, you may say something different, but I would say that really if you're offering a system where you've got the systems in place to support home-based collection, maybe you've got a telehealth model and you're doing a consultation on the phone, then you're sending the swab to that person's home, or they come in to collect the swab and then they take it home. I would suggest that really that's only suitable where you've got the dry system. So you're using, so that person can put it into the dry swab, and that's what gets sent off to the lab. It still has to come back to you to go off to the lab, but we know that's stable for 28 days, as Lara said. I think probably the challenges are too great. I mean, someone's not going to be able to suspend it at home, and just that time frame to get it back to you, and the systems that are needed to ensure that it gets suspended in the right time, I think are probably too challenging. But what would you say, Lara?
No, I'd absolutely support that. The time limit is really just a few hours to swirl that through the thin prep. And the other thing is, remember, we are at the other end of preventing cancer or significant abnormality of the cervix. So you need to be sure that the patient understands the responsibility, and you need to be able to support them to get that to the lab on time and within the specifications. I mean, with the dry swab, it can languish around for 28 days, but someone who's coming in for self-collection may be under-screened, and so ideally we want to be returning these swabs as promptly as possible. Back to you,
And
Deb.
I'll just add to that, just in terms of, obviously, it is preferable to support the self-collection in the clinic setting, because you then know that you're getting the swab back in your hands. Someone gives it back to you. You're going to send it to the lab. The lab's going to process it. You're going to get the results. You've got that system in place to give those results. Obviously, when you're adding in doing that at home, and absolutely, we want to open up access. This potentially opens up access to people who would otherwise not be screened. But you've just, as the ordering clinician, you do take that responsibility for ensuring that all of those steps are in place, and it really needs, that systems-based approach.
Thanks, Deb. We've had a suggestion for a video, and we'd be happy to look at doing that in terms of a demonstration. It's funny we haven't thought to do that as yet, but often we are demonstrating. And there
are some great videos.
Yeah,
I will say there are some good videos on the NCSP website
Yep.
About how to do self-collection, as well as paper-based resources and posters and things like that. But there are some videos which are worth checking out. But I agree, there could also be you, Lara, doing your unit video.
Well, and I think Trish might want to say something, but I think we'll get Imogen to find. No, okay. Thanks, Trish. We'll make sure that Deb, those ones that you're referring to. And I think hopefully if you're going to come, I've got to plug GP24. Sorry, Deb. But you may come along and see a live demonstration there. How about that? So, but we'll look into a video. It's a great idea.
It is.
Yep. I'm not sure we have any more questions.
They were great.
Oh, hang on. No. Yeah. There is a question there. I think, so is the approach best to offer this and give option to opt out? Could this be triggering? And why isn't this taught in high school as part of sex education? Yep. Love these questions.
Well, hopefully it is going to be now. Obviously there's quite a, now it starts at 25. But I think it's really important, I agree, that particularly, to know that the options, because often, people might hear about it from their mums about speculums, and people are just not getting the right information about the different options. So it's a really great idea, and hopefully that is starting to happen now too.
So Deb, I'm actually going to push our GP there a little bit further. It was a job I had. I supported about 6 high schools, and I used to come and give the mother-daughter talks and the talks to the year 9s and 8s. Deb, I know that family planning in your day and others have done amazing work and resources. But GP, you are a community leader. You're respected. Contact your high school. Put your hand up. And it's wonderful work, and see if you can help your local community. I'd encourage you to.
Excellent.
Deb, I'm just trying to understand the opt-out question. I'm not
sure. I think that came, yes. No, I think the context for that was when we were talking about just the approach to people where, you can't assume, or you don't know, and you don't want to be triggering by asking about prior sexual assault, but just offering, just having that offer of self-collection, of cervical screening to everyone who's age eligible. So I think it related to that. So is the approach best to offer cervical screening to people because they've turned 25 and they've come in to see you, but give the option to opt out? But I think the question is, could this be triggering? And I suppose, Tricia, it'd be useful to hear from you.
I was just going to say, I wouldn't be asking about sexual assault. I'd be asking whether they'd had any sexual activity. And, read the person. You're all good at doing that. Your patients. I'm sure somebody won't be coming in to see you for the first time ever. So you probably know your patients better than probably their mums do.
Trish, unfortunately or fortunately, we do see lots of people for their first time ever. So I think you know, one of the ways we're trained is actually according to demographics. We see certain demographics and we go, right, we have to do this, 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 and that. And I think the lesson from tonight and hearing from you is the way we might approach that. And often a 25-year-old female sitting before us is a red flag to a GP. Let's offer cervical screening. So I think we've heard a lot tonight about how we need to do that in a considered appropriate way. Back to you, Deb. I think Imogen's...
No, well, I think probably we've actually managed to cover all the questions, which is really great, and they're fantastic questions. So thank you. And I think it's 8:29, so that means that we're pretty much, you know, nearly there on time to wrap up today. But it's been fantastic, and you know, just thank you to Tricia and you, Lara, for Imogen as well, for being a fantastic person putting this all together.
Thank you.
Oh, well, thank you for those kind words, Deb. But yes, thank you to Deborah, Lara and Tricia. It's been so wonderful to listen to you this evening. And thank you to everyone for joining us online. As I mentioned, we'll get those resources to you. We'll get the slide deck to you. We'll be making the recording available. Please feel free to share with your colleagues. And we really hope to see you all online again sometime soon. So thank you, everyone.
Excellent. Thanks so much. Thank you. Good night, all.